Pfo, patent foramen ovale. Definition: foramen ovale is a tunnel-like space between the overlying septum secundum and septum primum. Typically closes in 75% of people at birth by fusion of the septum primum and secundum. Now, function of Pfo during fetal life. During fetal life, oxygenated blood from the placenta returns to the inferior vena cava directed towards the left atrium, crosses the foramen ovale and ultimately enters the systemic circulation of fetus. Now, closure of foramen ovale after birth. Lung expands. Just after birth, left atrial pressure exceeds right atrial pressure, resulting increase of pulmonary venous return. The thin flap of superior end of septum primum is forced to shut against septum secundum. Prevalence: approximately 25% people Pfo persist into adulthood. Size: average diameter 4.9 mm and increases with age. So, average diameter is 4.9 mm and increases with age. Clinical feature: usually asymptomatic, incidental diagnosis during echo. History of TIA, history of stroke, especially age less than 45 years, migraine headache. Decompression illness is in divers who work in high altitudes. Now, association of Pfo. What are the associations of Pfo? Atrial septum aneurysm, eustachian valves, a remnant of sinus venosus valve, Chiari networks, filamentous strands in right atrium, migraine headache, Platypnia, orthodoxia syndrome. What is Platypnia orthodoxia syndrome? It is dyspnea and arterial desaturation in the upright position that improves while lying down. Decompression sickness, arterial gas embolism from venous side. Now, pathophysiology of Pfo. Physiological condition: coughing, straining, Valsalva maneuver, and pathological conditions. Increasing RB pressure will raise right atrial pressure, favor right to left shunting. Source of paradoxical embolism in Pfo: pelvic vein thrombi more frequent. Now, diagnosis of Pfo, usually detected by transthoracic echo, transesophageal echo. Transesophageal echo most sensitive when performed with contrast media, projected during cough or Valsalva maneuver. If microvubbles are seen in the left-sided cardiac chambers within 3 cardiac cycles, confirms a Pfo. Other investigations are transcranial Doppler. Screening for prothrombotic states such as protein C, protein S deficiency, antithrombin 3 and lupus anticoagulant. Investigation is done to exclude other cause of stroke such as atrial fibrillation by ECG, carotid atherosclerosis by carotid Doppler imaging and brain MRA. Now, what is the treatment of Pfo? If asymptomatic, no treatment required. If cryptogenic stroke, isolated Pfo, antiplatelet for protection for prevention of future stroke. Pfo with DVT or high hypercoagulable state, then we will give warfarin. Recurrent cryptogenic stroke with aggressive medical therapy, then we will do device closure. When cardiac surgery is required for other reasons, then we can do surgical closure. Presence of congenital heart defect that needs surgical repair. Now, contraindications of percutaneous Pfo closure. What are the contraindications that are for percutaneous Pfo closure? They are severe pulmonary hypertension, presence of an alternative source of emboli, documented hypercoagulable state, presence of congenital heart defect that needs surgical repair. Now, what is the difference between PFO and ASD? PFO is a functional defect, ASD is an anatomical defect. PFO is tunnel shaped, ASD is oval or crescentic shape. PFO always right to left shunt. ASD usually left to right unless Eisenmenger's or pulmonary stenosis. PFO clinical features: diagnosis by contrast echo, RA RV normal. In ASD clinical feature 2D transthoracic echo or transesophageal echo, diagnosis by 2D transthoracic echo or transesophageal echo. In ASD there is presence of RA RV dilated. Now, paradoxical embolism with high degree of certainty, 4 point out of 5. What if paradoxical embolism with high degree of certainty, if 4 point out of 5? First point is prothrombotic state, that is prolonged immobilization, increased coagulability such as OCP dehydration, sudden onset of stroke during straining, during defecation, Valsalva maneuver or intercourse, pulmonary embolism within short time after or before surgery, absence of other cause of stroke. Reference are Bronwals and Griffin. Thank you.